Welcome everyone to Neuroimaging of COVID-19. We're pleased to be with you this afternoon, and hosting today is our moderator, Dr. Joshua Hirsch. Dr. Hirsch, please take it away.
Thank you. Let's allow people to come into the hallway. There's a queuing function on Ring Central, so please bear with us for a minute or two. Just another minute or two. Participants are dialing in, and in all of these kinds of platforms, people need to queue in a little bit at a time, just as if they were getting into a room. So thank you for those that got on a little early. And yes, for the person that's texting me, that is a little skull in the background. Indeed, we are neuroradiologists, so it's appropriate. Nothing eerie, nothing concerning, nothing to see here, just a teaching tool. We'll give 1 or 2 more minutes to get started. I wonder if we could advance to the next slide. I'd like to welcome everybody to RP Presents Neuroimaging of COVID-19. We're going to get started shortly. This is still an opportunity for people to join. There's an epic number of people that have registered at last count, 550, which is really spectacular. They're going to increase in real time. For those of you that are not speaking, which would represent the majority of people, we're going to keep you on mute throughout the seminar. Your control over the mute button on your own screen will therefore be limited. I think when you see what's going on with this presentation, you're going to be as excited as I am to participate, because we have 2 really spectacular speakers. I'll tell you a little bit about them in a second, but please know that questions will develop. The material that's been put together, including the case presentations by our second speaker, are just going to foster all kinds of questions. In order to facilitate answering as many questions as possible, we will use the QA function. So please put in your questions. I will do my best to collate them and translate them and present them to our speakers. You can see the disclosures. Apparently, I'm the only one with disclosures. Our planners and managers didn't have disclosures. My disclosures do not relate specifically to COVID-19 or to RP. All the speakers participating today are doing so on a voluntary basis, appreciating the opportunity for the platform. I probably should have disclosed that I'm a member of a societal COVID-19 task force at ASIPP, and I'm the co-chair of the of the ASNR task force. Let's go to the next slide, please. One of the exciting developments, I think this is the first time for RP, is that you can get CME credit associated with this event, and you'll see that this is a very standard CME approach, using what I think is actually a pretty cool vendor. They seem pretty easy to work with, which is a big positive. You'll see these instructions. The instructions will pop up again at the end, and again, this is so that you can claim CME credit. The easiest place to see this talk and or the slides and or find the instructions for CME will be at the radpartners.com website. they seem to be pretty dynamic. They said within 24 hours. From what I've seen, it'll be a lot quicker than 24 hours. Let's go to the next slide, please. So it's my great honor to be the moderator of these two incredibly accomplished individuals. My name is Josh Hirsch. As you can see, I work up in Boston, and I am the president of the American Society of Neuroradiology. Through really COVID-19, I've come to know Dr. Amit Mahajan. Amit has become quite a friend. I didn't really know him pre-COVID, so I guess this is one of the good things that have come out of this for me personally, and that I've gotten to know such a talented individual. He's a neuroradiologist at Yale. He serves as service chief for neuro-CT and head and neck imaging. He's an assistant professor in Department of Radiology and Biomedical Imaging at Yale as well. The thing that makes Amit so desirable in this era, beyond its encyclopedic fund of knowledge, is just the fact that he is unique, and in this case, uniquely trained as both an infectious disease doctor, an actual practicing ID doctor, as well as a neuroradiologist. That's made him, of course, one of the most sought after people in the neuroradiology community. I know you're going to find his talk instructive. Jennifer Hill, I've come to meet through this webinar. Wow, wait till you see her talk. It's just mind-blowing, actually. And I say that as a neuroradiologist, it's mind-blowing. So that carries extra weight. Well, Dr. Hill is a neuroradiologist at Renaissance Imaging Medical Associates, the largest private radiology group in LA and part of Rad Partners. She's a graduate of Stanford University with a degree in bioengineering. She attended UCLA for medical school residency and fellowship in neuroradiology. I guess she liked it. She practiced in Renaissance Imaging Medical Associates for almost 20 years and currently serves as the president of the practice. And when I say that her cases are outstanding, take that from me having done quite a few COVID-19 webinars. With that, I'm going to hand the platform over to Dr. Amit Mahajan. I'm sure you're going to enjoy his talk. Take her away, Amit.
Thanks, Josh, for the introduction. And thank you all for joining us this afternoon in the middle of your workday. But I hope you learn something out of this talk. So I have no disclosures, as we already said. And my topic is neuroradiology of COVID infections. And I'm going to try and move this slides. Okay, so yeah, so we are still in the midst of this epidemic, as we all know. And so I call this an epidemic in evolution. And I'm gonna go through this talk today in two parts. One is to show you the published cases or studies or whatever we've learned so far, and then try and come up with the etiopathogenesis so as to understand what exactly is happening with these patients who are presenting with neurological manifestations of COVID infections. So we all are aware of the worldwide situation now, 21 million cases, 750,000 deaths around the world. And this is the situation in the United States. From New York Times, we had a peak, a little decline, and then a huge big peak again of new cases, and now again on a little bit of decline right now. As far as deaths are concerned, we had much bigger deaths in April as compared to now. So that's good to know, but still worrisome. And again, from New York Times, showing you the total number of cases so far. So the biggest balloons seem to be in the Northeast, New York region, California, and Florida. And the deaths also seem to be much more have happened more in the New York area than in the other two regions. So when the epidemic initially started, we all thought it was going to be a respiratory disease. And this is what we all thought with it was going to be a viral infection. And soon we figured out that it was going to cause respiratory disease. And these were the typical findings of peripheral lung opacities, some degree of crazy paving pattern, and peripheral based opacities within the lung, which we were expecting. And also these were what we were expecting to cause ARDS. However, soon in late March, the case reports started to pour out. This one is from China without any supporting imaging, suggesting that they found a case in which the CSF PCR was positive. And then there was another case from Japan showing you a positive CSF in the PCR, although negative from the nasopharyngeal swab. So these were kind of worrisome and raised the concern that there may be neurological manifestations of this disease as well. Then there was this larger study. Again, this was from Wuhan, China, of a study of around 214 cases admitted to the hospital. And in this particular image, they showed lung lesions as well as these hypodensities in the left side of the brain, as well as on the right side, which they felt to be related to infarcts in this particular patient. And this was their data, and in which of 214 patients, most symptoms seem to be non-specific. If you look here on the top bracket is the most were dizziness, headache, impaired consciousness. More specific symptoms were acute cerebrovascular disease were seen in only 6 patients out of 214, of which 5 were severe and 1 was non-severe. And other more specific symptoms were ataxia in 1 and seizures in 1 more patient. And similarly, there were other findings of taste abnormalities and skeletal muscle injury were also reported. So this created a scare among us that we need to be worried about the neuroinvasive potential of COVID-19. And there were these animal studies in mice in which you could see the virus when instilled to the nose, it could go through the olfactory neurons into the rest of the brain. So this is what we were worried about. But then as time passed in early April, we found this French study in which they could do MR in around 13 patients, and they described leptomeningeal enhancement in 8 of 3 patients and ischemic stroke in 3 of these. None of their patients with this severe infection had positive PCR in the CSF. So these were some of their images in which you can see these non-specific findings within the brain parenchyma of these positive flare abnormality, some leptomeningeal enhancement. And also on this particular case, you can see this thickened mucosa within the sphenoid sinus, probably related to the disease in the respiratory tract. And there was another image from their study showing you this lacunar infarct in the cerebellum in this particular case. So these were kind of early times. But as time progressed, again in mid-April, we also realized that there were a lot of thromboembolic episodes happening within these patients with respiratory disease. And as you can see in this particular patient with severe lung opacities in the PECT, you could see this large filling defect within the right pulmonary artery. So it suggested that there was more going on than just a respiratory syndrome. And along with this, we also found emboli in mesenteric vessels, as seen in this particular case with, within the SMA, and also thereafter emboli and thrombi in the brain. And this was just an image from the lung showing you these microthrombi within the lung itself, which was seen on histopathology. And also we found elevated D-dimer in the blood, around 60% in patients with severe disease, and even 43% with non-severe disease was also reported. So this was followed by the scare of sudden strokes in young adults. And this is the new tool of medical education is Twitter. Is everything new first appears on Twitter, followed by any other news outlets. So this was kind of the first reports of COVID-19 causing a prothrombotic state around early April. And then by late April, CNN was already broadcasting that that strokes were happening in young patients. And this is the first study by Oxley et al. From in NEJM, excuse me, which showed these young patients who had developed these stroke-like symptoms, and most of them did not have any risk factors, and then also 2 of them did not have preceding symptoms from this particular disease. And if you look, their D-dimers were elevated, except for maybe 1 patient in this particular cohort. And this was followed by data from Mount Sinai on 123 stroke codes. They found COVID positive patients were 41 and around who had ischemic infarct as compared to 82 who were COVID negative. And so they felt that the COVID-19 was an independent risk factor for acute ischemic stroke in these patients. In 45 emergent large vessel occlusions from Mount Sinai, around 53% were COVID positive. And most of these patients were younger, but 15 years younger, more likely to be male, more likely to be white. Sorry, less likely to be white, less likely to have AFib, and less likely to have heart failure. And this was presented in our ASNR this year. And this was followed by another study from NYU in which they were able to kind of scan 252 patients with MR, with brain imaging, which the rest of the places were not doing. And they did 207 CTs, 11 MRs, 24 had both. And most of these findings that they found were non-specific white matter changes, chronic infarcts. However, acute to subacute infarcts were seen in 13, around only 5%, of which 4 had large vessel occlusion. Also, they found acute intracranial hemorrhage in 4.5%. 4 were unrelated and 1 was post-traumatic. And if you look at their numbers carefully, most of these seem to be large vessel strokes, and a lesser number had lacunar strokes. Also had hemorrhagic stroke in 9, also hypoxic anoxic injury in 2, and encephalitis was reported in 1 patient. So these were their representative images showing you an infarct in 1 patient, multiple infarcts in 2nd, and hemorrhage in the 3rd. Similar findings were reported from Barcelona as well within the same time period. They found 13 ischemic events and 7 hemorrhagic events of 103 participants. They did not report any encephalitis in their patients. Subsequently, other syndromes have also been reported. These have included cerebral venous thrombosis, and the image on the left showing the superior sagittal sinus thrombosis, while the image on the right is showing a hemorrhagic infarct in the thalamus and thrombosis within the internal cerebral vein in this particular patient. Other syndromes that have been included CNS vasculitis-like pattern. This is the DWI images showing you these multiple lesions within the supratentorial infratentorial brain, and also post-contrast enhancement within the basal ganglia and the cerebellum in this particular patient. One more syndrome which has been described in this press-like encephalopathy with perivascular gadolinium enhancement. You can see these press-like changes in the white matter. And in this post-contrast images, you see these tiny dots of post-contrast enhancement. But this patient was pretty late in their clinical stay, and it was around about 30 days after admission to the hospital. Subsequently, Guillain-Barré syndrome was also reported. Of these 5 patients reported from Italy, 2 of them had caudal nerve root enhancement, and 1 had facial nerve enhancement, while 2 patients did not have any abnormalities seen. And they were mostly presented from like 5 to 10 days after the onset of symptoms. And this is representative images, again, from ASNR, showing multiple cranial nerve enhancement in a somewhat atypical case of Guillain-Barré syndrome. One more finding which in the spine that has been described as paraspinal myositis in this particular patient on the STIR images on the left, and post-contrast enhancement on the right. And this was an interesting case of steroid responsive encephalitis in which there were no findings on MR. The MR was totally negative, but when they tapped the CSF, they found elevated IL-8 levels. This patient was treated. This is their profile of their inflammatory markers in the CSF. And the patient was started on high dose solumedrol, and following which the CSF markers seem to have come down and patient was able to be discharged. So this was interesting since the findings were only seen in the CSF and not in the systemic compartment. So I looked at what other countries are reporting as well. So UK reported in a 3-week period, 125 patients. Most of them had CVAs, similar ischemic, hemorrhagic, CNS vasculitis, and others. However, around 39 of their patients had altered mental status, of which 16 had encephalopathy, and 7 had encephalitis. However, they don't seem to separate out necrotizing encephalopathy from from a definite brain involvement in their particular subgroup. This is another multi-center study from Italy called NCOVID, in which they had complete data in around 25 patients, and of them, most of them, their patients were eMRI negative, which means there were no MR findings in most, and then a few had positive non-specific MR findings. One patient has limbic encephalitis, and 2 had ADEM. So this was kind of the bigger study, which has been in pre-publication right now. And these were their representative images. They were showed acute necrotizing encephalopathy, the case of ADEM, limbic encephalitis, a positive MR and a negative MR from their paper. So in summary, what are we seeing on neuroimaging? So what we're seeing are, one is strokes, which present with focal neurological deficits. We're also seeing the so-called encephalopathy or encephalitis, which could be non-specific brain changes. And then there is a more specific are vasculitis or ADEM, Guillain-Barré syndrome, and then cranial nerve palsies. So how do we try and decipher the etiology of these neuroimaging findings? So I've tried to kind of categorize them. This could be due to viral effects or due to coagulopathy, inflammatory response, comorbidities like hypertension, diabetes, complications of treatment, which include anticoagulants and ECMO, critical illness-related complications like hypoxia, and maybe dialysis-related, which includes stress. We all know the interaction of the spike protein from the viral membrane with the ACE2 receptor on the human cells. And this seems to be critical for the viral entry into the cell. And as we know that this ACE2 is present on the respiratory epithelial alveolar cells, but also in the GI epithelium, vascular endothelium, and tubular cells of the kidney. So once the virus interacts with this receptor, it seems to activate the monocytes and cause release of all these cytokines like IL-6, etc. And this somehow kind of stimulate the extrinsic coagulation pathway, and fibrinogen is released, which somehow leads to clotting, and then the D dimers are elevated in the blood. So this seems to be kind of the pattern in which the virus is causing a cytokine storm and monocyte activation, and then thereafter thrombi formation. And one thing which has not been well studied till now is the role of host factors. Not everyone is presenting with a severe form of disease. So the disease can vary from mild, moderate to severe. And what impacts these is not quite clear. So it could be the comorbidities, the obesity, hypertension, diabetes. Also, role of prior coronavirus infections in patients also needs to be studied to see how it leads to subsequent host changes. So this is a kind of a slide to see, show you what the how often the symptoms are happening and the frequency and timeline of these symptoms. So the most common we said was the disordered coagulation state, which is kind of the para-infectious kind of setting. And in the other para-infectious disease is the cytokine storm causing the necrotizing lesions in the brain. The third are the post-infectious syndromes, the immune phenomena, which basically include the ADEM, GBS, neuropathies, and these seem to be happening kind of later course of the disease. And finally, the direct viral effects seem to be less common, but it could include anosmia, and encephalitis is still not clear as whether the virus can cause encephalitis or not. So this is a couple of slides on anosmia. The images published in literature have been disparate. I mean, the first images showed presence of something in the upper nasal cavity, but then this particular study on the left seemed to show that there is nothing within the upper nasal cavity, and the olfactory bulbs are normal in size. There's another paper which has come out showing you the enlarged olfactory bulb. So I think it's all up in the air. We do not know why anosmia is happening so far. But this is interesting to see that the cells within the upper nasal cavity have a very high receptors of ACE2 and this other receptor called TMPRSS2. So both have to be present for the virus to get in, and they are in high supply within the upper nasal cavity, similar to the lung parenchyma itself. And so maybe it's a microscopic level thing, which we are not able to pick up on imaging. And this was kind of another interesting thing to note for us neuroradiologists is where are the ACE2 receptors within the brain parenchyma compared to the lung. So the lung is obviously much more, but you can see the ACE2 is high in substantia nigra and spinal cord, but less, they could not find ACE2 within the cerebellar hemispheres and the cerebellum itself. So this is kind of good to know. Finally, what is the evidence for neuroinvasion? So all we have are animal experiments that I showed you before in rats, observations from SARS in which they have showed that there could have been neuroinvasion. The two papers that we saw of positive PCR in the CSF, although most studies since then have not showed positive PCR within the CSF. And finally, this one autopsy case report, again out of Mount Sinai, which seemed to show viral inclusion within the endothelial cells. And this is one image in which they seem to say that this is within the neuronal cell of the frontal lobe in this patient with the COVID infection. However, this is still in pre-publication, this study in which they have autopsied around 35 brains and histology in 20. And most of their findings have been microthrombi and acute infarction. And also similar things that we talked about, large territory infarct and hemorrhage in deep gray matter. Their most consistent abnormality was the presence of microthrombi associated with small patchy infarct, which is similar to what we saw in the lung. And they specifically said that widespread meningoencephalitis and viral inclusions were not a prominent feature in the brain parenchyma, as well as they could not find olfactory bulb involvement on their pathological specimens. And these are one of their the specimens showing you these microthrombi within the vessels of the brain. And this is a staining for ACE2 on the endothelial cells, but not so in the brain parenchyma itself. And so in conclusion, what are we going to see on neuroimaging? I think that the key point to remember is we're going to see all these coagulopathies, all these thrombotic episodes and hemorrhagic manifestations, which are going to be the most common thing. And then there are the para-infectious phenomena due to this cytokine storm, which basically includes the acute hemorrhagic or necrotizing leukoencephalopathy. Most of the so-called encephalitis from the Italian and British studies may be all these acute hemorrhagic leukoencephalopathies. And the third would be these post-infectious etiologies, which basically include Guillain-Barré syndrome and things like Guillain-Barré syndrome, etc., which we talked about. And finally, neuroinvasion may be manifesting itself as anosmia, and however, the presence of encephalitis has not been proven yet. So I think that is the last of my slides. Thank you for your attention.
Amit, that was just brilliant. I mean, you know, I remember when it was February and March, how you were so far ahead of the curve, and it feels like every night I'm learning on cable news more about the COVID-19 epidemic. It seems to me that you've managed to stay ahead of my fund of knowledge despite learning from the notable talking heads on TV. I really feel like you bring so much more knowledge than most of those folks. You should be on TV. It was really a pleasure to hear you. I just want to encourage people as we transition to Jen, who, as I said, is going to show you just amazing cases. You do not need to wait till the end to put questions in the QA box. They're already beginning to queue, and I will try to batch some of them. So if questions come up while you're hearing these talks, please go ahead and put them in the QA box as you think of them. With that, Dr. Hill.
Thank you, Josh, and thank you, Amit, for that great talk. I'd also like to thank everybody out there who's taking time out of their day to join us in this ever-evolving discussion, neurologic complications of COVID-19. As a neuroradiologist, I feel like every day we're seeing something interesting. And as Amit said, it started out as a respiratory disease that has quickly become much a part of my practice. So with that, I will try to work the slides. So first, I just thought I would do an overview of the neurologic manifestations of COVID-19 that I'll be demonstrating in my case presentation. As has been said already, we find that the thromboembolic complications are most common, including large vessel occlusion or branch or small vessel occlusion strokes. We also are seeing intracranial hemorrhage, posterior reversible encephalopathy syndrome or PRESS, hypoxic injury, acute tumefactive demyelination, isolated cytotoxic lesions of the corpus callosum, acute necrotizing encephalopathy, cranial neuropathies, meningitis, and encephalitis. And many of these cases are from my Los Angeles practice, thanks to my colleagues, Dr. Diana Chuljan and Dr. Brian Zung for sending cases to me, but also to some other members of our community that I will share with you as we go through the cases. The first case is from Dr. Con Nguyen at RP Houston. It involves a 77-year-old male with underlying hypertension and diabetes who's found to be COVID positive. And on day 11 of his hospital stay, developed acute altered level of consciousness. The X-ray shows a typical pattern of COVID with patchy peripheral, interstitial, and nodular opacities. And a CTA from this case demonstrates large vessel occlusion with abrupt cutoff of the M1 segment of the left middle cerebral artery and paucity of distal branches in the MCA territory. So kind of a common thing that we are seeing in these patients. The next case is a 71-year-old patient presenting with altered level of consciousness, COVID positive. This is courtesy of Dr. Jacob Ormsby from University of New Mexico School of Medicine, and it's really quite a profound case of thromboembolic complication. Here you can see the diffusion-weighted abnormalities involving both thalami, the occipital lobes bilaterally, the splenium of the corpus callosum, and also portions of the superior cerebellum and pons on the right. There is rather extensive involvement of the upper aspect portions of the cerebellum and also left paracentral pons. An MRA from that patient demonstrates occlusion of the basilar artery and superior cerebellar arteries and posterior cerebral arteries. So rather a dire thromboembolic complication. The third case is an 81-year-old male presenting with acute left-sided weakness. This is from my colleague, Dr. Noriko Solomon from UCLA Medical School. You can see on the left-hand side, we have restricted diffusion, hyperintensity on the diffusion-weighted images and a watershed territory distribution of the right cerebrum. The perfusion images demonstrate a much larger area of at-risk ischemic brain. And then the concomitant upper lung fields demonstrate that patchy ground glass opacities with some peripheral consolidation compatible with COVID. A CT angiogram on this patient demonstrates eccentric soft plaque all around the cavernous carotid artery. And interestingly, the next day shows it partially recanalized with much less soft plaque. The patient did not develop as large an infarct as could have. Case 4 is a 73-year-old man presenting with an altered level of consciousness and left hemiplegia. This is from my colleague, Diana Chuljan, where you see here hypodensity in the posterior right frontal lobe with gray-white matter obscuration and evidence of petechial hemorrhage within the infarct. The CT angiogram as part of our code stroke workup was essentially negative. We did not find a large vessel occlusion, nor do we find a high-grade stenosis in the internal carotid arteries. However, we did find, interestingly, at the bottom of the films, as often is the case, we found almost a floating thrombosis emboli here and thought that this was the thromboembolic source for this patient's stroke. The next day, the patient had a CTA of the chest for shortness of breath, and you can see that the thrombus is gone. But the top of the lung fields demonstrate classic COVID with peripheral consolidation, some crazy paving, and ground glass opacities. Case 5 is a 58-year-old man with shortness of breath and cough. Here you can see the chest x-ray with interstitial nodular opacities, primarily at the lung bases and in the peripheries. And later, the patient develops left upper extremity weakness with 4 days later. And you can see that there is hypodensity in the cortex of the posterior frontal and parietal lobes compatible with small vessel infarcts. The CTA of the head and neck was normal, but again, you can see those COVID findings of peripheral consolidation and ground glass opacification. Case 6 is a 51-year-old female presenting to the ER with cough. She was admitted for her respiratory complications. You can see the patchy infiltrates here, primarily peripheral and lung bases. And during the second to really 6th week of her hospitalization, she had horrible encephalopathy, and the CT of the brain demonstrates this hypodensity in the posterior frontal and occipital lobes. It's involving subcortical and deep white matter, a pattern that many of us are really familiar with PRESS. At this time, we had not really been doing MRIs on our patients due to the infection control issues, but we thought that this was not your basic infarct. We were worried about PRESS, so we went ahead and got an MRI. And you can see the rather extensive changes in this patient with increased T2-weighted hyperintensity in the central pons, the middle cerebellar peduncles, and bilateral cerebellum. You can see the corresponding diffusion-weighted hyperintensity on the right image. And again, these are similar findings seen in the bilateral occipital lobes with T2-weighted hyperintensity and diffusion-weighted hyperintensity. And this corresponds to the CT findings quite nicely. You see extensive vasogenic edema in the posterior frontal lobes with that T2-weighted hyperintensity and relative sparing of the cortex. The diffusion-weighted images show sort of mixed signal intensity with the hint of possible restriction in the cortex. The ADC maps show most of this is really vasogenic edema. You can see that on the left with the hyperintensity here. We gave contrast, and you see this pretty robust but patchy enhancement of the areas involved, compatible with blood-brain barrier disruption. Is this endothelial injury from the virus itself or from cytokine storm? Interestingly, this patient was not on dialysis, which was my first thought. Case 7 is a 61-year-old man with respiratory failure. And you can see somewhat an ill-defined patchy infiltrate in the left lower lobe. This is a case from my colleague, Dr. Brian Zung, who shared this with me. The CT was done for worsening encephalopathy on day 4 of admission. You can see the hypodensity in the pericallosal white matter and also within the splenium of the corpus callosum and the left body of the corpus callosum. These findings were quite interesting, and we were able to get an MRI as well, revealing T2-weighted hyperintensity and flare hyperintensity in the corpus callosum and adjacent white matter with a normal MRA. And the findings that we thought were compatible with acute tumefactive demyelination. Diffusion-weighted hyperintensity was also seen in the pons, and of course in the corpus callosum and pericallosal white matter, some of which was restricted, and you can see here on the ADC maps with hypointensity in the corpus callosum, but the pericallosal white matter did not seem to be as restricted. Here's another image of involvement of the corpus callosum in this patient with extensive cytotoxic edema of the corpus callosum. This is a similar case, 33-year-old man with diabetes, morbid obesity, hypertension, and chronic kidney disease who developed respiratory failure, was found to be COVID positive, and developed acute altered mental status with extensive posturing. This is an amazing case provided to me by Dr. Amit Mahajan from University of Texas Southwestern. And again, another case of acute tumefactive demyelination, where you see gross involvement of the corpus callosum with flare hyperintensity, as well as pericallosal white matter. You can see the diffusion-weighted hyperintensity, as well as little areas of patchy enhancement. Case 9 is a 41-year-old female presenting to the ER with respiratory failure with somewhat of a typical past medical history in these cases with uncontrolled diabetes, morbid obesity, and chronic kidney disease. The X-ray showed interstitial pneumonia, and the patient was found to be COVID positive. The patient developed intranuclear ophthalmoplegia and paralysis. And a CT of the brain showed cytotoxic lesion of the corpus callosum, which has been described with other viral illnesses as well. This also is a case from Dr. Amit Mahajan at University of Texas Southwestern. And this is just another image of the involvement of the corpus callosum here, the splenium. And this patient also had subarachnoid hemorrhage in the right parietal region, perhaps related to coagulopathy or platelet dysfunction. Case 10 is a 52-year-old patient with altered level of consciousness and COVID positive. Again, many thanks to Dr. Jacob Ormsby for this case of cytotoxic leukoencephalopathy, where you can see on the diffusion-weighted images extensive involvement of the cerebral deep white matter, the cerebellar deep white matter extending into the middle cerebellar peduncles. Case 11 is a 71-year-old female with altered level of consciousness, COVID positive. This is from my colleague at UCLA, Dr. Noriko Solomon, where you can see acute white matter infarcts and leukoencephalopathy. We have here diffusion-weighted hyperintensity within the deep white matter, pericallosal white matter, and the corresponding ADC hypointensity suggesting acute ischemic change in this patient. Interestingly, we thought we may see susceptibility artifact with microhemorrhages, which we do not have evidence of here. Case 12 is a 58-year-old female with 3-day history of cough, fever, and altered level of consciousness. Found to be COVID positive on the nasopharyngeal swab, but was not able to be tested for the CSF. The CSF was negative, however, for the usual viral issues such as HSV, varicella, and West Nile. We can see here that we have on the CT brain, this is published in Radiology, where you have medial thalamic hypodensity, and you can usually, we think of things to rule out, including the internal cerebral vein thrombosis, but here they're patent, and you can also see that the basilar artery and branches are patent. An MRI was performed here, and you can see T2 weighted and flare hyperintensity within the amygdala and mesial temporal lobes, as well as bilateral thalamus. Susceptibility artifact was identified in these areas of signal abnormality compatible with hemorrhage, and you see patchy irregular enhancement, and these findings are compatible with acute hemorrhagic necrotizing encephalopathy. Next case is a 72-year-old male with altered level of consciousness in the ICU for 3 weeks. I saw this case on call the other day and did not know the COVID status. And I opened up what I thought would be a routine CT brain to find quite a spectacular hemorrhage in the corpus callosum and actually going into the septum pellucidum. So the patient also had at the same time a CT pulmonary angiogram that showed classic findings of COVID with the peripheral consolidation. We see interstitial crazy paving and some ground glass opacities and small effusions suggesting a more advanced stage of COVID-19. When I called to talk to the patient's nurse, and indeed the patient is COVID positive. These are a couple of images from the literature. I have not yet seen this, but COVID-19 associated Miller-Fisher syndrome, a variant of Guillain-Barré. And here this was an AJNR, and you can see enhancement of the left third cranial nerve down here, and T2 weighted or hyperintensity as well. Case 15 is, Amit had shown this briefly, a case of meningitis and encephalitis. It was one of the earliest case reports from Japan that demonstrated SARS-CoV-2 in the CSF, but interestingly not in the nasopharyngeal swab. And here these imaging findings, we see restricted diffusion along the lateral margin of the right temporal horn thought to reflect ventriculitis, as well as T2 weighted and flare hyperintensity in the hippocampus compatible with limbic encephalitis. And here we see some paranasal sinus disease. And the final case is, again, thanks to Dr. Jacob Ormsby, another case of limbic encephalitis in a 64-year-old with COVID positive testing. So with that, I thank you very much for allowing me to share these interesting cases, and I'll pass the baton.
Oh my goodness, Jen, I think everyone will agree that there was truth in advertising. Those cases are just spectacular. Let me start with a couple of bookkeeping items. One of them, I've been getting so many texts. Amit did a great job reminding me that everybody on this platform would have access to the landing page at the ASNR website. Amit is the co-chair of the COVID-19 task force. And on that site, you can find all kinds of open access or free access articles, links to helpful health policy and econ things, really just a tremendous amount of stuff reflecting his efforts. So if you're interested in learning more, that would be at the ASNR website. There were some bookkeeping questions that were sent in. Is there CME provided? The instructions are on the page right now. In addition, let me highlight the radpartners.com website where you can just go afterwards and follow up on this later. An additional question had to do with whether there will be a recorded video. The answer is RP or the team that I've been dealing with, whomever that is, I think it's internal people at RP, have said less than 24 hours. And in my recent experience dealing with them, that may mean 24 minutes. I mean, I'm being a little facetious, but I suspect you'll have this video posted soon. Please be sure to get your questions in. They're coming fast and furious. Let's start with Jen. Jen, would you say there's a correct answer to the following question from Beth? What is the first line test, CT or MR, when you're working up neuro COVID? Or is it based on what the person is presenting with?
Yeah, I think that for our practice, we really do start with CT. The modality is much easier to keep clean, less stress on the technologists and staff around. And depending what we see on CT or depending on the clinical situation, we may kind of on a case-by-case basis go into MRI at this time.
Amit, Gul Munoz showed some amazing cases where patients had anosmia. They still struck me. I mean, I remember them months later. How often do you see neuroradiologic manifestations related to the finding of anosmia versus just the clinical finding of anosmia with COVID-19?
I mean, I don't think we have enough imaging, first of all, Josh. I know that most of us have been leery of opening up our scanners for so many neurological manifestations. And so that is, I think, a big barrier to kind of understanding how often does it happen. I mean, all we have is little case reports. I think I found 3 different case reports and everything is disparate as to what they are saying. So I've not found anything which is consistent to explain the symptom of anosmia on imaging.
Sticking with you, Amit, how long does the anosmia last once one has it? Is it permanent, or is it something that when the infection dies down, it disappears?
No, it seems to improve following resolution of symptoms. So it's supposed to be a transient symptom rather than a persistent or a permanent loss of sense of the smell of sense.
Back to you, Jen. The person who preferred to remain anonymous wanted to know whether or not when you do the MRI, it's incumbent in these cases to give GAD, or would you again judge that based on the indication like you would any non-COVID case?
Yeah, we took it on a case-by-case basis, and also, the underlying patient situation. For patients on dialysis or with renal failure, we would withhold gadolinium. But for those folks that were able to get it, we've been giving gadolinium to see if it's helpful in any ways that we might not anticipate.
This is a question for both of you. It's an aggregated question because there are a lot on the sort of same thing, and you can probably tell that I'm getting information overload with people texting the QA box, etc. And I am going to aggregate a couple of questions here on pediatrics. So maybe we can start with Amit and move to Jen. We hear a lot about the very unfortunate young people that sometimes get stuck with COVID. I mean, actual clinical manifestations of COVID. Are there known neuroradiologic manifestations of COVID, or have there not been, I guess we can pray, enough patients to have them? Let's start with Amit and then move to Jen.
You're saying the pediatric age group?
Yes.
So, I mean, there are a few reported cases. One was a reported case of meningoencephalitis from San Francisco. And then there was another one in which they had done vessel wall imaging in a person. I think this is published in ASNR, COVID website, in which they did post-contrast imaging of the vessels and showed enhancement of the vessel wall itself in a particular patient, 11-year-old with COVID infection. So that I thought was interesting because of the way the kids are presenting with MISC, that is in which they have like a Kawasaki-like syndrome, in which the vessels, the myocardial vessels are involved. So to have a similar correlate within the cerebral vessels is kind of interesting to see. Although, so, as I said, these are just case reports, and I think we need to look at more cases before we say that the brain is definitely not involved. I mean, especially we are seeing more and more of these post-infectious disorders now. So similar to MISC, could we have more of these post-infectious disorders in adults as well? I think it's still an open question, and we should keep an eyes open for those.
Jen, after you respond, I think I'm going to make a point about what Amit just said. But Jen, any further thoughts on things you've seen in terms of pediatrics?
I think I agree with Amit, and I know that the cases now are rising in the younger population, so we may be seeing some new things come about. But as to date, I have not seen that in my practice. I've heard anecdotes and case reports, but nothing seen personally.
You know, the thing I want to reflect on what Amit said, I think that it's an under-discussed challenge because of the level of the crisis, which is that we think about this incredibly fulminant acute illness. That's what captures people's mind. But I think in years to come, we may be reading about things that were neuroradiologic insults or neurologic insults that occurred that were, let's not call it subclinical, were close to clinical, maybe a little clinical. Thank goodness people got past the acute, this is going to kill you type period, but then who knows what those will mean. So I think COVID's ugly hand will be with us for a long time. Amit, let's go to your infectious disease days. We actually have a question. I would have thought it was a plant because it's so reminiscent of the early stuff you were teaching us about. But this is from a Dr. Sharda. Could you tell us a little more about Cytokine Storm, and knowing you could talk about it forever, just sort of hit on the key point?
Yeah, so basically, I think what we are trying to show as a part of the Cytokine Storm is that after the interaction of the viral spike protein with the receptor, which is, we say, the ACE2, and it also needs this co-receptor called the TMPRSS2. And if both of them are present on a particular cell, that's when the virus will enter the cell. And then thereafter, it will go and attack the monocytes within the circulation, and somehow lead to release of all these cytokines, the IL-6, IL-8, etc., TNF, etc., which basically go to the level of the endothelium. And in the endothelial surfaces, it activates the endothelium and leads to production of all these procoagulant factors, and which cause increased secretion of fibrinogen. And then the fibrinogen somehow, those high circulating levels kind of form clots, and within the setting of inflammation. And thereafter, as these clots are broken down, by the fibrinolytic system, that's when your D-dimers start to get elevated. So there is this dyscoagulation in which there is increased coagulation as well as there is increased fibrinolytic activity going on. And I think because of both their presence in the setting of inflammation kind of leads to all these manifestations of inflammation as well as coagulation.
I'm gonna summarize because the doctor sent another question about it. The cytokine storm, what I've learned from you is, especially in the early New York, New Jersey, Connecticut period before we understood a lot about this disease, actually that storm is what would kill you. The incredible response to this disease. And so much of what we see in terms of therapeutics works at mitigating against this storm. And I'm going to suggest to Dr. Sharda that ASNR site has quite a few articles, and in them there's at least one where I think Dr. Amit and I have all kinds of pictures on cytokine storm. That one was from Pain Physician, but there are others, I think, for purposes of covering the neuroradiologic specific manifestations. I'll move on, but understanding cytokine storm is really a big part of understanding this disease. Let's start with Jen and then move to Amit on this next question. Clearly, there's an overlap with vascular disease because this affects the endothelium, et cetera. So a two-part question. How would you compare and contrast, I guess, the findings to vasculitis, which is a fairly open-ended question, and then one from Esther Lee, which is a particular one. Have we seen increased cord infarcts with COVID, which I think is a very interesting question in light of how much we talk about the brain. Let's start with Jen and then we'll move to Amit.
Yeah, no, those are great questions. I think for, most of the, not that we're seeing a lot of this because we're not imaging folks, but thromboembolic complications are probably what I see most in these COVID patients. And these are large vessel occlusion or even small branch occlusion that seem a little bit different than the vasculitic involvement of deep white matter. Although I did show a case where I think it was more like a vasculitic complication of COVID. That was from Dr. Noriko Solomon. So I think there is some overlap there. Interesting case, the question about the cord, the spinal cord, I have not seen that. So that has not come across our practice yet, but it would make sense that we may see that in the future.
Excellent. Amit?
No, I have not seen any evidence of cord involvement yet, or found a report, reported case yet. So if someone has it, maybe definitely it's a publishable case.
There was a question, believe it or not, directed to me, but I'll then pose it to the group. So they were asking about PPE and neuro-IR procedures. I'm imagining most of the people aren't neuro-IR docs that are listening. So I'll answer that, but then let me pose it first to Amit, because I know you did a lot of work on this for ASNR, and then to Jen in terms of what you're doing in your practice for, let's say, more routine procedures that are going on other than neuro-IR. So for neuro-IR, the discussion was really pretty big because, as mentioned, you'll remember that at Mount Sinai very early on published their observation of 5 patients that were young having strokes in the New England Journal. And so everybody was focused on stroke and the COVID patient. My administrative responsibilities is really broadly procedural services at my department. So, there were so many different points of entry for this conversation. And we were at a tertiary care center where we fortunately never really got into trouble with PPE, but you would hear about our friends, let's say a couple of 100 miles down, having terrible trouble. The issue for neuro-IR procedures is, like other ones, aerosolized generating. The challenge with aerosolized generating or aerosol generating in neuro, particularly with stroke, which is really all we were treating during, well, amongst the stuff that we were treating during the real shutdown phase, is the concern that a person will need to be intubated emergently during the procedure. So there was a lot of conversation about shifting to more use of general anesthesia versus sedation because of losing the airway during the procedure. I would say that varies depending on where you practice, and different people do different things. I would say most people were using fairly aggressive PPE, and it would depend again on your local institution about what they would consider appropriate. Really, at our institution, it was top down. Obviously, people were doing what they wanted, but there was a very, very strong procedural services committee that would delineate how and what people would use, and they really tried to shy away from your personal decision because different things have different implications. Like, for example, if you treat something like a COVID-19 case, what do you do in the perioperative period, et cetera? So that's a quite long answer for the fact that neuro-IR was fairly diverse during the acute phase when we were on severe shutdown. It was mostly emergency and urgent cases. Now, I currently use standard PPE for my cases, and patients who are not emergent or urgent, for example, I do a lot of spine, I wouldn't treat them if they had COVID-19. It just wouldn't be logical. It's an elective procedure. Why don't we start with Amit? If you could expand the conversation. Let me first say I'm aware it's 4 o'clock. We have a huge number of participants still on the line, so I'm going to propose we go till 4:10, and we'll try to get to as many questions as possible. Amit, you spent some time thinking about PPE. Let's talk about specifically diagnostic procedures, and then Jen will pivot to you to find out what you're doing out in the real world with respect to PPE. Go for it, Amit.
Yeah, so basically what we have done regarding PPE is, and I mean, obviously all inpatients are being tested for COVID infection at admission. So definitely those ones seem to be well delineated by the time they reach us. So there's another group of the outpatients who we are not testing, and we are still doing procedures on them if required to. So if we talk about the outpatients itself, I think what we do is we definitely screen them clinically. Scheduler will call them to make sure that they do not have symptoms when they reach us. And then we make sure that we are able to have access to the N95 masks. And somehow those are readily available now than they were in the time of the epidemic, and we make sure that we use them during the procedure that we're doing. As far as, so we basically presume them to be positive and use N95 itself. As far as inpatient are concerned, obviously, now that we've screened them, there is that extra layer of security. And in that case, we still try to take enough precautions while doing the procedure. If they are definitely N95, I'm sorry, if they are definitely COVID positive, then we will go ahead and use the N95 and other protections, gown, glove, mask, etc. And if they are not, then people are using just plain masks, surgical masks while doing the procedure. And I think people have gotten comfortable to do those over time.
People quickly discover the N95 is not that comfortable for an extended case. Jen, anything you wanted to add to Amit's really outstanding answer?
Yeah, no, that sounds very similar. We too, at this point, know most of our inpatients are tested now. And so if it is a COVID positive patient, we do the N95 or a PAPR, depending on the procedure and the hospital. For our outpatients, we are only testing them for doing the COVID testing if they're going to be under moderate sedation or there's a risk that we think with the procedure. So otherwise, we're not testing, and we're doing clinical assessment on all our patients and just using regular PPE for those patients.
Thanks, Jen. I think it might be my mom who came in as an anonymous attendee, wrote 2 questions, which really were comments. Dr. Hill is wonderful was 1, and Dr. Mahajan is wonderful was number 2. And I'll just say, thanks, Mom. I appreciate that. But in all seriousness, I think judging by the number of people still on, you guys are knocking it out of the park. Here's a really interesting question from Junaid. Let's say, send this one to Amit because it's heavy hitting ID. Do we know anything yet about the various types, strains having different, and I'm going to add in neuroradiologic manifestations?
So first of all, I think I mean, if you look at our data coming from, say, UK, there were 125 cases they found out of thousands of patients who were positive for COVID. So that basically it's telling us the neuroradiological manifestations are not a very common manifestations. And also that CNS manifestations are not very common. They are kind of unusual and rare, but they do happen. So we have to be aware of them. And as far as different strains are concerned, I mean, there's a good website called the GIS AID, which basically has been tracking these isolates from all over the world. And they have more than 5,000 isolates by now. And ever since the epidemic started, they have been looking at the genome and kind of, different parts of the genome. They've been trying to track it out and see how each part of the genome is changing over time. And it's very interesting to see those graphs. And according to that, they can kind of track the spread of the virus from one place to the other. And it's very interesting how the virus keeps mutating a little bit at a time. But obviously, it has not made a big difference in its respiratory involvement so far. So in spite of all the changes within the virus itself, these have not been significant changes for it to stop infecting humans. So that means that all these little changes that are happening within the virus over time so far are not significant changes to make a big change in the infectivity of the virus or causing the damage to our bodies as as it's been doing for the last 6 or 8 months, maybe by now. So in a short, basically, it has not made much change yet.
And I'm going to follow up with a question from Karen. I think this is going to be very hard. Well, that's why I'm putting it to you. Better you than me. Have you seen a second case of COVID? What she clarifies she means is reinfection after complete recovery. I would suggest let's not answer broadly. We've read about reinfection in Wuhan. I would put that to neuroradiology. Have you heard about a case where maybe the person came back reinfected and now there's a neuroradiology manifestation, or something that would bring together those two concepts, reinfection and neuroradiology, rather than reinfection broadly?
Is it for me?
Yeah, that's for you.
Okay. So yeah, I think again, the neuroradiology part is easy since since we're not having any, since it's a rare or less common disease. So definitely having a recurrent neuroradiological disease is still undescribed, I would say. And as far as in reinfection is concerned, I don't think people have really accepted the fact that reinfection is happening. And this is even at the level of CDC and all the experts. There were some cases which came out, I think in May, maybe from Korea, in which they described this reinfection, but but they were based upon positive PCRs and stuff. So I think people kind of disregarded those cases and said that this could be just a persistent virus within the nasopharynx or the nasal mucosa for more than a month that the PCR was positive. And they don't really believe that reinfection is possible within a short period of time. Again, I mean, can this never happen? I mean, I can't predict everything, but I would say it's very hard for a virus to reinfect shortly after the initial infection that it causes.
Okay, thanks, Amit. Let me throw this question to Jen. Jen, this is from Anonymous. Is there a concern about Ghatto deposition if there is blood-brain barrier disruption with COVID? Interpret that however you would like.
Yeah, I mean, I think that we need to think about that. However, most of the cases with COVID deposition, with gadolinium deposition that I've seen have been repeated doses of gadolinium. And I have not yet seen repeated doses of gadolinium in a COVID patient, but I would be mindful of that. And yes, perhaps because of the possibility of blood-brain barrier disruption, it would be at a greater risk. But I have not I've not, with that concern, I haven't said no to gadolinium for a first case, for a first look at the MRI of the brain on a patient.
With 2 questions left before we wrap up, I'm going to ask that the CME slide be put back up. This one is for Amit. Amit, what cranial nerve palsy is most, and this comes from Alfonso, what cranial nerve palsy is the most common for neuro involvement? And I think I know the answer, but I'll let you say, and then I'll take credit.
No, I think if we consider less than 10 cases reported, the facial nerve palsy is probably the most common among them. But I'll let you answer that as well.
No, because I would have gotten it wrong. So I'm glad I didn't. I'm glad I didn't embarrass myself. So we'll pivot to Dr. Well, let me answer this. I thought the answer was obviously going to be the olfactory nerve.
Oh, okay.
Is it so obvious that that's why you were thinking of harder ones? It would have to be olfactory, right? Or maybe that's not a cranial nerve finding. Maybe it's a parenchymal finding. You're just being nice to me. Well, thank you, Amit. I appreciate it. I was thinking olfactory nerve because of the anosmia, but maybe it's parenchymal because all the pictures that Gul showed were really up in the parenchyma in that area. And so the last question is my own, and it's for Jennifer. Jennifer, we had the benefit, quote unquote, if you were where Amit was or where I am, where the kind of severe cutback in procedures kind of made sense. We were in the middle of the crisis at that point. California's experiencing the crisis now. How are you guys dealing with, there isn't sort of a national cutback, severe restriction on procedures. Is your normal practice going on in parallel with the Southern Californian expansion of cases?
Yeah, that's a great question. I think we found a precipitous drop in our volumes of regular diagnostic work, just like the rest of the country in March and April. A pretty profound decrease in outpatient imaging when the ACR was recommending against routine studies. We have slowly been creeping back up to normalcy, although I'll be honest, we're still shy about 15, sometimes 20% of our volumes. And that's really because there's a lot of conflict out there. We're reaching out to our referring doctors, letting them know we have safe practices for us to image patients. But a lot of patients are saying, I'll hold off on that screening study, or I won't come in for this. So we're trying to get the word out about, making sure that these patients are being taken care of medically and getting the appropriate imaging. We don't want to miss a lot of cancers and things like that. But it's a lot of effort with the referring doctors to let them know that we've got safe practices.
Jen, so that 15%, 20%, that's not specifically neuro. That would be across the practice.
Exactly.
Yeah. Yep. Yeah, it's it really, I would say, for us, there is at least some sort of, by luck, I guess, overlap for when the crisis was terrible here and when all these restrictions were put in place. As we're in recovery, our practice has an opportunity to kind of thrive. Meanwhile, if you're in California or Florida or Texas or any of those states, in a sense, the shutdown occurred before the crisis came in. It is curious how practices would deal with that. I as a final personal note, I really do worry. I treat a lot of patients with profound pain, what months of opiates means for them. I mean, we railed against that before COVID, and that became actually an alternative to good treatment. Similarly, all the patients you read about weren't going in for strokes. Now expand that to screening mammography. I mean, we believe in these screening tests actually saving lives, and to think about people skipping a cycle or months of not going in, and I could go on and on. I think there'll be years worth of study for what disruptions occurred as a consequence of the disruption. With that, I want to thank RP for hosting this. I want to thank my fellow volunteer panelists. This was really, I think, fantastic. Amit, you're an amazing resource. And Jen, you really brought just great cases from around the country. So with that, be sure to get your CME. Thank you very much, and we're adjourned.
Thank you, everyone, for joining us.